Hello. My name is Adrian Brown. I am an alcohol nurse specialist. Currently work at Northwick Park with my colleague Betwell. I have worked in this role in different settings, but we are currently linked in with the acute psychiatric liaison team who work in the hospital. But our role is predominantly on the medical wards. And I was going to talk a little bit about what we do, and also just to give you context, we mostly see people in acute medicine or in the gastrohepatology wards. Now, acute medicine wards, the presentation is often the initial stages of alcohol withdrawal. But of course, some of the population have had this problem for some time, and the chronic signs and symptoms might be representing in terms of liver damage, in terms of other health problems. So I'll say a little bit about what we do. I'll talk a little about the medical presentations, and then I'll just give you some context for why this is particularly important when it comes to alcohol-related liver problems. So this is an overview of the role. Many teams are alcohol and drugs focused in terms of the patients who are admitted with alcohol and drugs problems. I would say very often the role of an alcohol care team is focused on two sides to this job. There is the impact that people's drinking can have on their physical health, and therefore it can present complications or problems or complexities for somebody who's admitted to hospital for a planned admission, for a unplanned admission, for an emergency admission, for example. There's a whole range of different contexts. But there is also the idea that when somebody presents at hospital, we can take that opportunity to give them advice about their health. And this is often known as alcohol brief interventions or initial brief advice, various different acronyms that you would find given here. And I think all of us that work with dependent drinkers will know that there may have been many times during that person's life when they could have been given advice, or they could have taken advice and heard it and made changes to their drinking. It's very rare that people present to us with chronic problems who haven't had involvement with health and social care services prior to this, both from an effect of the way drinking affects their life, their day-to-day life, from intoxication through to illness at work, through to chronic health problems. I have a slide coming up where I'll just illustrate some of those physical health problems. So our role overall can be said to advise our colleagues from a specialist perspective about alcohol and drugs. And I think there are a lot of opinions about alcohol which sometimes can get in the way of somebody giving a fair intervention. But if we can realize that early on, we can give advice to people about changing their drinking and prevent chronic problems later on. Plus, if somebody is dependent or is getting to the more chronic and severe symptoms, that there are specialist interventions that need to happen while the person's in hospital. And that second part is probably where our job at the moment in Northwick Park, at least, is focused. That's because we have 1.5 nurses. An alcohol care team can have 3 to 5 nurses or alcohol workers who see the patients who have that specialist advice and input, but it does vary from hospital to hospital. So I'm talking about the ideal situation. We can be there to help support that care for the person in hospital. We can or could be providing brief interventions to people who presented with an alcohol-related presentation, perhaps early on. So the earliest presentations are often somebody who's intoxicated and has an accident or gets sick because of that alcohol involvement. And at that point, the advice needs to be something that they can listen to, something that they can hear and accept. So I think historically the sense of telling somebody off for turning up drunk at A&E has been shown that it doesn't really have the best impact. So you really have to understand, things like why that person is drinking, how that person's drinking affects their life, how they perceive it. And it's not always something that we have time to do in an acute medical setting. So we encourage people to talk about alcohol in a constructive way. And part of our role is giving our colleagues that advice, that confidence to be able to address this. There are screening tools that can help, but it is very much about the rapport that people get with the patients. So whilst our role might not give us the resources to go and see everybody who has a drink problem, we can do teaching and training and support for our colleagues that helps them to do that more constructively. But if somebody comes into hospital and they are dependent on alcohol or they're getting to more severe problems, when they leave hospital, it's what we call a teachable moment. It's an opportunity to advise them to make changes or find out if they had already been trying to make changes. Do they know about the services that are available when they go home? So we might be signposting people to community services. We're very lucky here at Northwick Park. We have 2 local services that send workers in to meet people in hospital. And we've found that this is really helpful to have not just the medical staff advising people or the nursing staff advising people about their drinking, not just a specialist nurse coming along and telling them a bit more and giving them a bit more focused advice on their drinking, but also to be able to say, this is a group of people that will help you when you leave hospital. I did mention the local services. I should also say we have links with local AA meetings. And again, somebody who's able to come on a voluntary basis, but provides a lot of support for people to find out more about Alcoholics Anonymous and also engage them and support them to get to meetings. So yeah, while this slide does describe an overall model of what an alcohol care team can do, teams do different aspects of this, but I think helping with assessment and care planning on the wards, providing brief interventions or training and supporting our colleagues to do that. Advice, monitoring and planning of care and ongoing review is the same thing. We see a patient who's admitted to the ward, we talk to them about their drinking, we find out what they know, we look at the level of withdrawals that they might be experiencing or that they might expect, and we set up a plan that takes that into account. Not really on this slide, but it's also worth mentioning is that we help the trust to develop guidelines, because when we're not here in the hospital, there still needs to be a protocol of what our colleagues should do, how they should find out about somebody's drinking, what they should do if they find out that the person is at risk of withdrawals or at risk of more long-term problems. And that's what I'll say a bit more about as I progress. So here's an example of a slide. I'm not really going to dwell on this slide, but it does give you an overall of 2 local services where I work. And as I said, both of these organisations send a person to meet and assess people to work alongside us. And because our role doesn't have the resources to work in the emergency department, it's actually really handy that both of these people will see somebody in the emergency department. It's often opportunistic. You can imagine that people with alcohol, high alcohol use or dependent alcohol use don't necessarily come in Monday to Friday, 9 to 5. So there's an opportunity for this person to be seen or followed up and given advice. When we look at medical interventions, I use this slide in my training because it really just shows that pretty much every organ, every specialty within the hospital can have some impact from alcohol. And some of these are more than others. If you were to ask a general question, most people would instantly think about the liver. But we also know that there's a long-term impact on the brain. There are cardio effects related to strokes, related to high blood pressure and so on, which are definitely increased by higher alcohol use. But as you can see, pretty much every organ of the body is depicted here. So we start off by giving people an idea of how to assess somebody, but this is also a conversation that we can have with patients that we see. If they have been admitted to hospital for alcohol withdrawals, they're likely to be already aware of some of this, but very often this is a secondary concern. They're admitted with an injury, they're admitted with chest pain, they're admitted with gastro problems, which might be related to alcohol, might be completely unrelated to alcohol, or as is often the case, a number of factors coming together. So, the usual reasons to be admitted to hospital that are directly alcohol related are withdrawals, especially delirium tremens, the most severe case, Wernicke-Korsakoff's if it's in the more prolonged, which is the Korsakoff's, which is kind of like a dementia. It creates cognitive problems. That might be seen to causing people confusion when they're talking about their symptoms. And at the top there, where it says physical consequences of heavy drinking, chronic heavy drinking can create liver problems across the spectrum of those. And very often it's where people can be picked up early because we can see early signs of the impact of their drinking on their liver, and we can give them advice accordingly. Say a bit more about that as I go on. I started to talk about Wernicke's and Korsakoff's where people are confused, and very often the person themselves isn't able to give a good account of their drinking, ranging from not being able to tell you how much they had to drink today and how long they've been in hospital and when their last drink was, through to not really understanding that their drinking has caused them a secondary physical problem or what they see as unrelated to alcohol problem. Very often people with gastric problems or with oral cancers is a kind of common source of referrals. Whilst people might think, oh, this is my liver, so it might be alcohol related, people don't always make that association with other presentations. And they might be confused about this because their memory is poor, they may have had misinformation, or they may be what people are often refer to as in denial. I'm using it here to give an example, but it's not really a term that I favour. We tend to talk about people not really understanding their level of their drinking, either because they don't remember for the reasons that I've just itemized, or they've never really been given the correlation. They've never really been said, you know, this could be made worse by alcohol. And it's really important that that conversation happens in a constructive way for everybody. So, whatever the presentation and whatever they're giving, there are tools that we can use and that our non-specialist colleagues especially can use to be able to quantify how much somebody's drinking. We would say there's the audit C is probably the most well validated thing, but sometimes we look at withdrawal symptoms because the person's not able to give you, or people don't necessarily believe the answer that they've been given about how much a person drinks. So then we look at alcohol withdrawals. And so we're training our colleagues how to recognize those symptoms. And this comes from an old presentation that I was doing with nurses on an acute ward. And I asked them, what are the top three things you would look for in someone who's got alcohol withdrawals? And you can see some pretty good signs and symptoms. But the three most obvious and the three that actually were the top answers. So this was quite gratifying when I asked quite a big cross section of the nurses on the medical wards in the emergency department. What would you look for? Shakes and sweats because they're instantly visible. Hallucinations, especially with people who are not previously having symptoms. Yeah, this is teaching people what to look for and then also getting feedback from them that they have learnt from the presentations that they've seen and from their talks that we've given to our colleagues. So this was quite good feedback, as I said. Seems like a basic question, but when we talk about drinking, people don't always know about units of alcohol. I'm not going to dwell on these slides now, but I just wanted to quickly give you an illustration of how simplistically we take that and explain. But mainly, you know, we're talking about being able to quantify different strengths of alcohol. When I do this presentation, very often in the notes, it will say drinks 1 bottle of whiskey a day. And I often have to say to the patient, what size is the bottle that you're drinking? And so when we're giving teaching sessions to the doctors, to the nurses, to other colleagues, I do kind of say to them, double check what people are drinking. Ask them about the strength of beer. Ask them about the size of the bottle that they drink. And very often people can't remember how much they drink in a day. So how often do they buy a new bottle of whichever spirit, or how many cans of beer or bottles of wine they're drinking? Just getting people to think about it in that way in the teaching sessions. And also when we're giving feedback, obviously we try to quantify the patient's drinking as part of our assessment. So it's there are teaching sessions, but every referral is a teaching opportunity. The general advice given about drinking, that is to say, if you go to the drinks industry websites that are targeting all drinkers, there are things about how to control how much some are drinking, what the recommended advice is. Very often people don't go to this level with a referral to, say, to the liver specialist team, outpatient liver specialist. You're seeing a patient, you know that they drink too much. So the best advice is to tell them to stop. But does the person find that helpful? So we're talking to people about how they can slow down their drinking, especially useful in the emergency department where the majority of their presentations are actually somebody who's intoxicated and has had an incident or has become ill whilst they've been drinking. Much generally, a much younger population. Once again, this is an opportunity to advise people in a constructive way to make those changes. And all of the info that I've given so far is about what we tell our colleagues they can do. Our role in the education of this is also to get feedback from people. Do we need to clarify the advice? Do we need to tell them something more specific? And obviously, if you've got somebody who has come in with a specific presentation that is alcohol related, alcoholic cirrhosis, alcohol withdrawals, we do need to be more specific. A person with withdrawals in general needs to have a period of abstinence. Given different types of advice, they might be told to remain abstinent altogether. And if they start drinking again, it might be considered a relapse. So we have to work with people across a spectrum of understanding about what their drinking is doing to their body or other aspects of their life. The recommended guidelines are 14 units a week for men and women. Some people might know that it used to be a whole range of up to 30 for women and 50 for men, but that recommendation is at the higher level. So overall drinking, there's less of a difference between men and women, but the heavier drinking, and you can see in the middle cirrhosis, and bottom right you can see heart disease, ischemic heart disease, and you can see changes as people are drinking more heavily. But what we know is that a lower level of alcohol daily can do more impact to women than it does for men with certain conditions. So that's why the guidelines used to be different. In recent years, 14 units for men and women. It's simple. It's based on this kind of evidence about the more you drink, the more risk, the more harm, and the more potential harm, I should say, to various organs of the body. So trying to give people the evidence without overloading them, trying to tell them more about what's going on. And if I'm talking about a patient who has hypertension and doesn't have the other things, or a patient who's come to A&E with an accident because they were intoxicated, we can inform them about the higher risks and the later risks, but we need it to make it person specific. So as we're talking about people with liver problems, I think this NC pod report and its follow-up, measuring the units and remeasuring the units, looked at what would happen with people coming in various specific liver-related deaths. And what we know from liver presentations is that people can attend several times without receiving advice about their drinking. This is one of the findings of the NC pod report. And I think, what we're trying to say to people is that early intervention is vital. So if we're getting a presentation with early signs and symptoms that liver is in some way struggling to deal with the alcohol, that we should advise people about the connection and the possible prognosis. The fact that the NC pod report showed that so many people were not given interventions, obviously this is based on a population who died. We do know that there's a very good awareness now that any referral to a liver specialist is likely to get at least brief advice and, where appropriate, referral to the local services, or if there is somebody working in a hospital, referral to the alcohol care team. So considering all of the implications, considering all of the risks, and being aware that if it goes unadvised, then or advised in a non-constructive way, then there is a risk of the sad longer term consequences to them, their alcohol consumption killing them. As I just said in the previous slide, adequate alcohol history not taken in nearly half. Now I get referrals, and my colleagues, we get referrals in the hospital, which often say something simple like ETOH excess, alcohol excess. We hope that that's been quantified based on the units that I said earlier. We could take referrals for anybody who's drinking more than the recommended guidelines. There is the Audit C, which allows you to actually stream people to a specific type of intervention. Obviously, in most screening tools, there are several options which you might miss cases, but at least if you were screening people with the Audit C, it tells you this person's likely to be dependent, this person at lower level, not dependent perhaps, but they're drinking at a level where harm may come. So an adequate alcohol history from me should start with the Audit C, should start with how much somebody drinks, how often they drink, and then go on to the more specific qualitative questions. So, in my assessment, I might find out more about their drinking history, reasons that they're drinking, why they carry on drinking, even though they've been given this diagnosis. But I wouldn't necessarily expect colleagues to focus on that. Because it can be quite a difficult one for the patient to navigate and for the professional to navigate. Secondly, because you want to focus in an acute medical setting on the acute medical concern, and then you want to give advice about long-term consequences. So, as I say, I'm not expecting everybody to go through the history when you first started drinking. How long has this been a problem? What symptoms have you had? If somebody is acutely withdrawing, we encourage them to ask signs and symptoms like, have you ever had this before? But we're not looking for a long-term history of the person's drinking. We're looking for what they drink now and what they know about their drinking. And that enables you to be able to make a constructive brief intervention with that person. And should they need it, you can then go on to refer to a specialist service. I think the second paragraph, advice given on alcohol intake was not appropriate in more than 1 in 10 cases. For these, they are specifically talking about people who were not told that because of their liver, they should stop drinking. The broader population, sometimes advice needs to be to reduce, have a period of abstinence, and that would be more objective and acceptable to the patient, but also more likely for them to deal with it. Treatment for alcohol withdrawal, I'm not going to go into a lot of detail on that here, but this was subsequent presentations. So it's often the case that people were not offered a detox. And firstly, a medical admission is not always the appropriate place to do that. But if somebody's in hospital for an acute presentation, then they're going to be in hospital for 2 or 3 days. It is important to monitor their withdrawal symptoms, and that's where we get involved. So if the person is drinking daily at levels that mean they're going to be dependent, here at Northwick Park, we would hope to be referred at the point that we could be most helpful to the team. We would hope to be involved early on. Some of the teams are very comfortable with doing alcohol withdrawal management. They look for the signs and symptoms, the shakes, sweats, etc. that I showed earlier, and they know what to do. But sometimes the case is complex. So just examples from the last few weeks, somebody has an infection, they're confused because of that, but they might also have taken other drugs, and we know that they drink a large amount. So what's causing this confusion right now? It could be acute alcohol withdrawal. It could be 1 or 2 infections. It could be another complication that we don't know about yet. And the reality is it's 2 or 3 of those things when the patient first came in, and they remain confused later on, and we're still treating them for infections. So there are a whole bunch of treatments that this person needed. Another case where treatment's inappropriate, although this is less concerning, it can actually delay somebody's discharge. If a person is recorded as drinking a bottle of vodka a day, But this assessment was done 3 months ago, and they came out of hospital. They come back into hospital. Oh, they drink a bottle of vodka every day. We should give them a higher level of treatment. This goes back to making that initial assessment. How much are you drinking now? How often do you drink? And things like when was your last drink? Because very often it's missed that this person actually took the advice and stopped drinking. And they might have had a relapse yesterday, but mostly they've taken the advice of the previous admission. So it's important to try and get that current history and recent history sorted out. Oh, I've talked about brief interventions, and I just wanted to give you this example of the slide. On the left is the slide that I've always used to show what is the recommended drinking. That's in a week. A lot of the heavier drinkers are drinking that or twice that within a day. But if you're looking at a couple of bottles of, very mild strength wine, not low alcohol, but lower level, Tennant Super and similar beers are higher content. And of course, most spirits are half bottle in a week. And we talk to our dependent drinkers, they're drinking that in half a day. So that gives you just a benchmark of what to expect. And I think these days there are way more choices in alcohol-free drinks or low alcohol drinks that people can switch to, remembering that sometimes low alcohol is an option. It is going to help that person's health. But if you think the person's physically dependent, or if you think that they've got more extreme liver-related presentations or more chronic liver ailment, then obviously the best advice is to stop drinking. The slide that I showed earlier, just to recap, we'll do assessments, we'll help people to do brief interventions, but some teams do the brief interventions. We'll give advice for a care plan for somebody who's in hospital, and that might be, yes, give them some sedation for the alcohol withdrawals, or keep an eye on them because you might need to give it, or no, this person's got plenty dose, start to reduce it now, and we can get them home safely more quickly. We don't need to do a formulaic detox in hospital, but we do follow a protocol to make sure that acute withdrawals are dealt with. Ongoing reviews, so we'll go back. If you think about it, if a person's admitted to hospital today and they see the alcohol nurse specialist today when they're very concerned about what else is going on, they might not be taking everything in, they might not be trusting us enough to tell us what's going on. So sometimes the review is just about building their trust and about building the idea that they might seek help when they leave hospital. I've talked about referral and signposting, and yes, if you can get the people from the services to come in or make contact while the patient's in hospital, that's really helpful. And liaison with the key workers, I didn't really talk about, but we get a lot of people on prescriptions or in recovery programs, and we let their key worker know that we've seen them in hospital. So I think I mentioned at the start that here we're part of the psychiatric liaison team, and within the psychiatric liaison team, there are often dual diagnosis issues, or somebody with a mental health problem is also drinking, also taking drugs. But there is such an overlap anyway between what people understand as mental health, mental illness, and addiction or dependence on substances. So a lot of people do both. A lot of people are expected that alcohol shouldn't be allowed with certain conditions, and they're given advice based on that. So we're working with a psychiatric liaison team to give them some more info. I feel like I've gone through a lot of the aspects of what a team can do without really telling you much about my day-to-day job. I've tried to give illustrations, but just to give you an idea, anywhere in the hospital wards can make a referral to our team. In some of the hospitals, as I say, anywhere within the hospital system, so outpatients, which is really important for early interventions with the liver teams especially. And then also we're talking about a presentation for somebody who's been in several times. So you're following up that intervention. You get a relationship. And it's some of the longer term liver patients that need to get admitted to the hospital several times, they will see us several times. Sometimes they're not relapsing, but their alcohol related liver problems are longer term and need a longer period of abstinence. Very commonly, of course, people have relapsed, and we're talking to them about what they can do differently, was there a trigger? Was there something that they could have changed so that when they next go home out of hospital, that they can have a healthier aspect to their drinking? Thanks again for taking the time to listen to this.